morning, everybody, and welcome to Friday Chalk Talk. My name is Kristen, and I will be your moderator today. I consider it a great privilege to be able to introduce to you our presenters today, Indrani and Joshua. They are the authors of the 2023 article, Clinician Self-Disclosure in Palliative Care, Describing a Taxonomy and Proposing a Communication Tool. Indrani Barua is a psychiatrist and psychotherapist in private practice in Chicago, Illinois, as well as a psychoanalyst in training at the Chicago Psychoanalytic Institute. Since completing the Hospice and Palliative Medicine Fellowship at Northwestern in 2018, she has continued to collaborate with her palliative care colleagues in applying psychotherapeutic concepts and techniques in the palliative care setting as an adjunct lecturer in the Department of Medicine at Northwestern University, Feinberg School of Medicine. When not seeing patients or spending time with her family, she sometimes gets to accompany her professional musician husband as a percussionist or dancer. Joshua Hauser is a palliative care physician at Northwestern Memorial Hospital and the Northwestern Feinberg School of Medicine, where he directs the Palliative Care Fellowship. He is also section chief of palliative care at the Jesse Brown VA in Chicago. Dr. Hauser lives in Evanston, Illinois, and is a father to 2 college-aged children. Our format today will include a 15-minute presentation, followed by a case study, after which we will have our typical 5 to 10 minutes of Q&A. So, Indrani and Joshua, I pass it off to you.
Thank you so much, Kristen and Marty. So we're going to be talking about clinician self-disclosure as a boundary crossing and a communication tool. Josh and I have nothing to disclose at the time. We're going to try to spend 10 to 15 minutes on an overview, and then Josh will be presenting a composite case, maybe something from his recent work in palliative care, and which we'll try to apply the tool that we're going to be introducing today, and then hopefully have time for Q&A, maybe even some cases from you all. So our overall goal is to increase effective boundary management, specifically by learning how to think about and use self-disclosure more intentionally today. Before we begin, I'm going to ask a few questions of you all, and please think about these, remember things, hold those in mind as we move forward. So first, have you ever voluntarily, without being asked, shared personal information with a patient? Have you ever been asked to share personal information by a patient or by their family? Have you ever not been sure if you should share personal information with a patient? Do you think you've experienced a time that sharing personal information seemed to help? Have you experienced a time that sharing personal information seemed not to help, or maybe even hurt? Try to keep those in mind. So to start, we're going to review what we mean by clinician-patient boundaries and the benefits of these boundaries. So you probably all remember from medical ethics, your professional training, that the clinician-patient relationship is a fiduciary relationship. This means that it is a relationship in which there's a person, the patient, who is entrusting his welfare to the clinician, who has expertise, and the patient is paying a fee to the clinician for provision of that service. And literature that focuses on the fiduciary relationship and professional ethics really emphasize the limits defined by these boundaries. In other words, what's outside this relationship. So things like dual relationships, financial gifts over a certain financial amount, right? And of course, sexual contact, romantic contact. Now, psychotherapeutic literature adds to that. Obviously, in psychotherapy, we talk about what is outside the relationship, but we also explicate, what is inside the relationship. And I think it's important to know what is usually inside and what's usually outside so that things don't get too messy. So what we learn from psychotherapeutic literature is that these boundaries define what we call the therapeutic frame. So medical ethics teaches us these boundaries protect patients. Psychotherapeutic literature teaches us about the frame and what that means. This is the relational space that allows deep listening by the clinician, relevant sharing by the patient, and therapeutic use of the relationship to foster healing. In palliative care in particular, this means that patients and clinicians can engage with those feelings associated with life-limiting illness and death in more effective and healing ways, because they're within this frame in which discussion of these difficult themes is explicitly acceptable and encouraged by consistent, helpful, available, yet appropriately boundaried clinicians. So I'm going to take that one step further and say that these boundaries facilitate healing by defining the therapeutic frame. Now, of course, we probably all are aware in reading literature about burnout, boundaries are one component also that protect clinicians by helping us take care of ourselves. And that, of course, also improves patient care as well. So how do we navigate this space? What is inside? What is outside? Where is there wiggle room? Is there wiggle room? How do we be curious but respectful of these boundaries? So first, I think it's important to clarify the difference between a boundary crossing and a boundary violation. Much of the literature now defines a boundary crossing as a harmless deviation from traditional clinical practice, behavior, or demeanor. And we can probably all remember moments where we've crossed a boundary, gone outside our usual way of practice, and this resulted in a delightful interaction with a patient that filled our cup, was an antidote to burnout, right? These moments where we are humans relating as humans that remind us why we do this work. In contrast, boundary violations are typically harmful and usually exploitative, erotic, affiliative, dependency, or authority based. And there's a whole lot of gray area in between, literature about clinician misconduct, clinician violation, patient abuse, very clearly tells us that boundary violations don't come out of nowhere. It almost always starts with a harmless boundary crossing. So it's very important to be aware of this slippery slope, not only for patient safety, but also for ourselves. How much are you giving of yourself before you find yourself overextended? So Josh and I focused specifically on clinician self-disclosure as a boundary crossing. This is verbal or nonverbal behavior on the part of the clinician that reveals to the patient personal information about the clinician that is not otherwise known from the context of the interaction. So lots of different types of self-disclosures, lots of different contexts for self-disclosure. How do we think about them in these different settings and in these different ways? Josh and I developed what we call the CSD framework, sort of algorithm for approaching these instances. And we started out by building upon the existing literature about there to develop this taxonomy of self-disclosures. We've identified 4 axes that we can describe self-disclosure with. The first is whether or not it's elective or unavoidable. So this has to do with the degree of control that the clinician has over whether or not the disclosure enters the treatment space. For example, there are always unavoidable self-disclosures: gender presentation, race, certain physical disabilities, pregnancy. These come into the therapeutic space with you. On the other side of that, there are things that we elect to introduce into the treatment space. Then we have conscious versus unconscious. You might have heard Josh making a joke about that. This comes from psychodynamics, that there are things that we are self-aware of all the time, right? That we know what our motivation is, can reflect on that. And then there are other unconscious motivations internally and external events that might motivate our behavior. So for example, I'm gesturing with my hands. This is not something I am thinking about. This is a procedural behavior, right? It just happens. I do not have to plan it and think about it, right? Then there's intentional and unintentional. And this is specific to the treatment space. Is the clinician intending this to promote the treatment goals? And this can include promoting a positive treatment relationship. And then there's immediate versus non-immediate. How immediately related is the self-disclosure to this clinical moment, this clinical context? So here we have our framework, CSD, clinician self-disclosure, classify, stop, and describe. So step one is to use that taxonomy. Once you notice you have the impulse to make a self-disclosure, can you think about what kind of self-disclosure are you trying to make right here? Step S, stop and reflect on your motivation. And finally, D, describe potential benefits and potential risks. So this is basically a communication timeout, right? Stop and pause. Why am I thinking of this intervention at this time? Is it the right intervention for this time? What are the potential risks? What are the potential benefits? What is my goal here with this communication intervention? All right, Josh, do you have a case for us?
Thanks, Indrani. So as an internist palliative care physician, it's been such a treat to learn about this topic from Indrani and from others. One of the neat things about this topic is that it sort of is on the borders of a lot of different practices, whether nursing, psychiatry, psychotherapy, psychology, internal medicine, et cetera. And then I'll just, in the spirit of this class or this time, I'll make a self-disclosure that I'm the son of a psychiatrist and the son of a social worker. So that's a lot of personal things for me. So Indrani, you and I are gonna talk about a very brief case for a few minutes, and I'll just present in a few lines something that just happened to me just earlier this week, actually. So I was seeing a patient in the hospital here at Northwestern, and I'm going to give some general details that won't be identifiable, but it was a woman who has metastatic cancer, but actually has a very good functional status and is in hospice. And we were seeing her because she fell at home and fractured her hip. And so that was the focus of our consult, mostly on her pain and just getting to meet her. And pretty rapidly in the course of our very first visit, we asked, how was hospice going? Because she was in hospice and she was aware of that. And she said, it's okay. And this is a quote. She said, but the nurses come and talk about their life, their kids, and their family. And I sort of looked and had Indrani on my shoulder and wondered how to process that and think about it. I'll add one more detail, and then Indrani, you and I can talk. That when I asked her what was that like, she said it was really annoying. And then her son said it was suboptimal. So that was a little bit of a reaction to that disclosure. So Indrani, those are a few details I want to share. Tell me how you want to think out loud with me about it.
All right, Josh. If you were the nurse, I guess, and you could go back and reflect on that visit, what would you think about here? Step C, classifying this disclosure.
Yeah. So it felt pretty elective, and by the way, my presenting it in the way that I did is not meant to cast shade on any nurses at all. That is something that I could have done in any number of circumstances. Talk about my family. The reason I'm presenting this case is just because it's very immediate in my mind. So this was a very elective thing that the nurse had control over whether to talk about. It's interesting whether this was conscious or unconscious. I'd like to think it was somewhat conscious, although I think a lot of us sometimes defer pretty naturally to talking about our family. So that's an interesting variable there. And the treatment goals axis is a really interesting one for me, Indrani, because I wonder about how intentional it was in trying to build a connection with this patient, which is really a good treatment goal. But I worried, quite frankly, if it had, because of what they told me, if it had the opposite effect. And also if it even took time away from something like evaluating her home situation in terms of what the risks for falls might be. So in an economy of time, spending time on disclosure versus spending time on loose rugs and things like that. And then the present clinical moment, it wasn't really, I'm kind of looking back, it wasn't really related to an immediate clinical moment. It was sort of made at, a general visit. Those are a couple of the ways I think of the classification.
So I think is really the conscious, unconscious level, intentional, unintentional levels are really interesting here. So some of the literature we reviewed, and as you all might imagine, there isn't a ton of empirical, controlled studies about this topic. A lot of it is case reports, a lot of it is surveys of clinicians, surveys of patients. But one trend we noticed is that the context of the setting really mattered. So for example, surgeons and in the emergency room, a little more self-disclosure was helpful there. In contrast, in primary care settings, more self-disclosure tended to be harmful there, that patients were not comfortable with that. So it's interesting for me to think about when someone's coming into the patient's home, how does that change how a self-disclosure is going to be received, right? You're in the patient's home, it is an intrusion, right? I mean, it's necessary that you're there, but it is an intrusion. And then if you start oversharing in the patient's space, what is that going to feel like to the patient? So although a lot of the literature out there, clinicians often feel like they are trying to promote the positive treatment relationship, is often not received that way.
Great, thank you.
And then the conscious and unconscious level, I mean, there's no way for us to know, but we might theorize a lot. In my time in residency and fellowship, I felt like it seemed to happen more on like weekends and on call. And that's just anecdotal, right? But is there something happening where the clinicians are away from their family and maybe would rather not be in the hospital or something? And that's motivating some of this behavior as well. All right, so Josh, if you were that nurse and could go back in time, or next time you make a home visit and you feel this impulse coming up, what might you do now that you've made this classification?
Yeah, I mean, I always assume amazing motivations for all of us. So I think the motivation is clearly to connect. I mean, that is the ultimate motivation that we all have in taking care of patients, obviously. I wonder, and I'm combining S&D here, that the degree of disclosure in that setting, and again, I have the virtue of getting to see the outcome, so I'm spoiled in that respect. But I think the degree of disclosure in that setting, as described by the patient, so I'll sort of use that as my marker, was just sort of too much, and really, took the focus away from the patient herself and her son in this case. Indrani, as you know, one of the articles about this topic is from the primary care literature, where the title is something like "Enough about you, what about me?" Where you is the patient and me is the physician. And again, the physician could be the nurse, could be the social worker, could be the nurse's aide, et cetera. So motivation to connect, which is an amazing motivation, potential benefits equals connection. The risk is in deviating the focus from the patient and the family. And it sounds like it happened here. So I hope that that's a helpful lesson to me the next time that I'm in that kind of a situation. And I think an important sort of realization.
I would point out, I think also thinking again about context, also the role of the relationship is going to vary as well. You know, you talk about nurses, aides, nurses, the physician, the social worker, the chaplain. What each of those persons' role is in that person's care is also probably going to affect how these types of disclosures are received as well. So something to keep in mind. I think that gets at, what was that?
I said, thank you. I agree.
I think sort of like that, you know, surgical situation versus primary care, to me that brings up there's that power differential in the fiduciary relationship, right? In the surgical situation, it's a really acute situation. It's a existentially acute, right?
Mm-hmm.
You know, primary care, you know, annual physical exam where generally you're feeling well, not as existentially acute. So does that power balance, that power differential need to be thought about, need to be leveled out maybe for some patients in a helpful way?
Great.
Right.
Andrani, do you want to open it up to some questions and comments and anything else that might be on people's minds?
Absolutely.
Wonderful. So what I will do is I will manage the chat. And if anyone elects to use their raise their hand function, and so I'll just make sure that our questions are asked in, I guess, a reasonable order. So, Marty, it looks like you have a question or two. Would you like to begin?
Love to. All right. Thank you, guys. Let me pretend to play the skeptic. So elective self-disclosures, they have potential slippery slope. They have potential for risk or harm. And we have all these other tools in our toolbox that don't tread into boundaries and can build rapport and promote treatment goals. Why take the chance? Or is there something about self-disclosure that other tools just can't match?
It's a really, really great question, Marty. I don't think there's a clear answer here. I think that for some patients, being more human with them is going to mean more. And for some patients, that's not going to be helpful to them. And sometimes I think of it as kind of like I had a supervisor in residency who talked about it like palpating, like where is it tender, right? And what kind of response, where's the guarding happening? And you might try something, and you know, if it has a little risk, maybe potentially large benefit, and you try it and then you don't get that benefit, then you have an idea of where to go next, right? So, and then I think a lot of it depends on the clinician too, right? This, you know, not to get too esoteric about it, but what we are talking about is using the self, right, as a therapeutic tool. And there are some clinicians who are more comfortable with that and some who are not. And it would not be very authentic to their self, right, to be disclosing. And I think that people pick up on that as well, right? I think the way
I appreciate the point. It's such a good one. And you know, I think another thing that I've thought about over many years with this is sort of identifying moments of self-disclosure, and then what is the degree to which we'll indulge those moments. Excuse my language of indulgence. But so literally just yesterday, a patient started talking about music with me, and I'm particularly interested in a lot of different music. And he named a band that I'm really into. The band called the Sex Pistols, for you punk music fans on the call. And so I said that, oh, I enjoy their music too. Now, I could have gone way down that path and talked about my history and, enjoying punk music and concerts I've gone to and dot, 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 dot. But I didn't go that far. But I did do a little bit of a nod to saying, oh, I've enjoyed them too. And then the conversation really went to sort of his experience in music. So that's a titration point as well.
In our paper, Josh provided this one example where we kind of explore that titration, right? If you can identify that stop moment, right? What is the motivation? And then the D moment, what is the goal here, right? So how I would describe that from a self-psychological perspective is that Josh was promoting a twinship with that patient. They can identify with each other on their taste in music. Right now, none of us is exactly alike, right? So if Josh keeps going with that discussion, at some point they're going to find a point where they're not the same anymore. And then that twinship gets just disrupted, right? So how much do you go to promote that relationship, that joining together, which is very beneficial for the treatment, but without risking throwing everything off track? Sorry, one more point maybe to Marty is I think what you might also be picking up on here is that because of that power differential, the fiduciary relationship, any disclosure is inherently manipulative as well. And that can mean, the lay connotation of that is coercive, right? But it doesn't necessarily have to be that if it does promote the treatment goals, but we do have to keep that in mind.
Eve shared a reflection that I appreciate. She says, I feel like it comes to intention and meeting a patient where they are. Sometimes a little self-disclosure can be the door opening to the soul. Maybe piggybacking off of Marty and Eve's questions and observations, I'm curious if there are certain behaviors or even personalities that, as you both have worked with patients, if these behaviors or personalities trigger something in you that says, oh, I wonder if a little bit of self-disclosure could be very effective here. Is there anything that comes to mind for the two of you?
I'd love to hear your perspective from your experience, Josh. My experience these days is pretty narrow, so I can share that. But
yeah, no, I'm smiling, Kristen, because it's such an interesting question. My initial reaction is that this is a patient who's kind of like me. He's kind of middle-aged white guy, and that's like going to be a self-disclosure moment. But it actually, as I'm thinking about your question, it's such a great question. It's actually usually the opposite. It's usually patients who I don't, and I gave some pretty superficial details about me, middle-aged white man, who I don't sort of superficially identify with. And that's sort of sometimes why it's so powerful. So in other words, someone who might not look like me and who might be of a very different age and different gender and different socioeconomic class, et cetera, et cetera. I often think in those contexts, it can be really powerful, for reasons, again, our ultimate goal of connectivity is sort of where my mind is at. So I don't have a clear answer other than what for me is somewhat counterintuitive, that it's not the sort of people that are, at least superficially, I most identify with in terms of some of those characteristics that I mentioned. Thanks for the question.
I think perhaps I notice it or find myself using it more with people who tend to be more avoidant of relating, avoidant of sharing. For example, the very common palliative care communication tool of disclosing, your emotional reaction, right? So patient gets some new bad news. Maybe you're not quite sure how they're responding to it, or you are maybe having a theory or hypothesis about how they seem to be taking this news, and you might put out there, I'm worried, right? Or I'm concerned. And I think that those can be really powerful moments for the patients who might hold that stuff close to their chest, right? I think that not only brings you two closer in similarity, I think also changes that, again, that power differential. You know, are you this clinician giving them cold hard facts, or are you a person sharing this experience with them?
Thank you both. Marty, I'd like to circle back to your question about AI.
One last quick question before we conclude for the day. So AI feels like an inevitability. It's going to be part of our job someday. Maybe there will be AI palliative care clinicians. And I'm curious about how self-disclosure is going to impact that, because does self-disclosure have to be real to be helpful? Can it be fake? Can it be scripted? Can you give this robot a backstory and it connects on some way? Or can I even make up my own little backstory as I connect? I'm curious on your thoughts on some of that.
You got an answer, Josh?
Yeah, I mean, you definitely can make up a backstory, Marty. As can we all know. All kidding aside, I think it's a really good and provocative question. You know, I do think there's something about you know, authenticity and genuineness that self-disclosure, I think, taps into, which is probably why it feels like an important tool for many of us. And again, that includes many of us on this call, I'll bet, and many of us in the world. So it's sort of the ultimate thing that, again, I can do that's different than Marty and different than Indrani and different than Kristen and different than anybody else. So AI does pose a really interesting challenge or paradox in that. So I have no idea what the answer to your question is, other than what is interesting about self-disclosure, different than a lot of other things in medicine, is that it's sort of the ultimate personal thing by definition. And there are awesome things about that, and there are hard things about that.
Is it a, you know, interesting topic, obviously coming up in the therapy world these days. But you know, I think people talking about using AI have this fantasy that it can be perfectly empathic, right? That a person will always feel understood, always feel met where they are. The problem with that is that that's not real. I'm not going to perfectly understand my patients, even the patients I have the best, closest relationships with. And part of the healing process is in recognizing each other, I think, as real, and coming to terms with us being the same in some ways and different in other ways, and still being able to connect despite those differences, right? And I think that AI, you know, it's really lacking that. I think one therapist said something like the problem with it is that you can't have the experience of being loved even with your hateful parts, right? AI can't do that for you.
Well, what a note to end on. Thank you both so much for your thoughtfulness. I really appreciated the case study as well. I'm going to be walking away thinking about even how could I evaluate whether or not my choice to self-disclose was effective or suboptimal. So we appreciate you. Thank you to our participants. And we look forward to seeing you in future weeks.
Thank you so much for having us.
Thanks so much, everybody. Thanks, Marty and Kristen, for leading this. Appreciate it.